Good evening to one and all present here. It's a great opportunity to again sit on a Sunday evening and to talk on a niche topic. So that this time we have Dr. Narayana Subramaniam with us. He doesn't really need any introduction, but anyways, he is a national and international award-winning head and neck onco-surgeon from India. Having completed his training in India with MBBS being my classmate and followed by excellent training from various places, which includes India, Australia, and United States. He specializes in complex tumors, rare tumors, salvage and redo surgery, and primary dental rehabilitation. He has significant expertise in major and minor salivary gland tumor management too, including skull-base surgery and facial nerve reanimation. He has previously edited popular textbooks on head and neck oncology and another on rare tumors of head and neck. Of course, he has multiple peer-reviewed publications, almost amounting to 150 odd numbers, including multiple lectures, national and international. One of the noted important thing is the number of grants he could gather so far, almost touching up to $3 million in clinical and translational research. So today he will be sharing his expertise about dysphagia after head and neck cancer surgery, predominantly as a guide for a gastroenterologist. Thank you, Dr. Narayana Subramaniam, for joining us in this podium and to share your knowledge. The podium is entirely yours. Thank you for accepting our invitation despite your busy schedule. Thank you.
Not at all. Thank you. Prashanth and I have been good friends for many years, and the admiration is very much mutual. So I think this is a great opportunity, the Evolving Gastroenterologists Association, an ability to, I think, connect with people from different specialties for people who are relatively new to the field to understand, where they can make an impact. So we all have our areas within our specialty where we can make a big impact for our patients. But I think more and more, everything that we do is multidisciplinary. So even if we are very good at what we do, working well with people from other specialties ensures that we do a much better job for our patients. So today I'm going to talk about dysphagia after head and neck cancer surgery. And this is more of a collaborative management guide for gastroenterologists. So rather than me telling you what happens, it's more telling you my perspective, and hopefully getting some perspective for you and then seeing what we can do best for the patient. So this is the outline. It will be maybe 30, 40 minutes, not longer than that, but this is the rough outline. So the scope and impact of head and neck cancer treatment. So what's the epidemiology? PEG dependent. So very often what we think of reflexively is we send to the medical gastroenterologist for a PEG, and that's the only involvement, but certainly not. We need more of their involvement in the rehab of our patients. And then also the impact of surgery and radiation. So what exactly happens when you treat patients for head and neck cancer? What impacts their swallowing? And what is the timeline? So what impacts it in the short term and the long term? How do we make assessments of a safe swallow? So where do we do a FEAS? Where do we do a VFS? If we have to protect the airway, who needs a tracheostomy? Very important. Enteral access, of course, PEGs are very important for many of our patients. And what is the strategy there? And then finally, rehabilitation of the GI. So very often patients have strictures and other problems. So where do you do dilatations? How do you work with the speech and language pathologist? So they play a very, very important role in the rehab of our patients. And then finally, what does a multidisciplinary plan look like? So even if we all do our own work very well, it doesn't have the same impact of as us sitting together as a team with different areas of expertise and working together in order to give a good result to our patients. So what that looks like and some takeaways, hopefully. So head and neck cancer is a huge problem in India. So it has amongst the highest incidences in the world. India, unfortunately, is the oral cancer capital of the world, 250,000 cases every year. So what happens as a result? It's a lot of these patients require treatment. And unfortunately, a lot of it is local regionally advanced. So 75% present to us in stage 3, stage 4, which essentially means that the treatment is multimodal. So many of them have surgery and radiation or radiation and chemotherapy. So the distortion to the upper aerodigestive tract is quite significant. Even if it looks normal, there are quite a few changes. So there is 60 to 75% post-op prevalence of acute to moderate severe swallow dysfunction. So whether you realize it or not, most of your patients have it. Most of them, if they have a good physiological reserve, if they're quite healthy, they get over it. They can manage that acute dysphagia, but some people don't. 25 to 35% have either a long-term PEG rate, which is at 12 months, or at least they have disordered swallowing. So they're not on a normal diet or a soft diet, they're on a blended or a puree diet. What's very, very important for us to realize is that when you intervene early, the rehab success rate is about 85%. So we now have multiple guidelines and multiple publications that show that when you intervene early, rehabilitation is very, very effective. So now we do a lot of big surgeries for head and neck cancer. And I'm happy to say that the number of people who are PEG dependent or tracheostomy dependent is very, very small. And the only reason for that is because of the aggressive rehabilitation and things like enhanced recovery after surgery. So we intervene early. Everybody gets like a protocolized rehab plan. So the plan for rehab is as important as the plan for the cancer itself. And when we are able to execute that and the patients are compliant and they have good social support, most of them have good speech and swallowing. So, how does surgery impact things? So, the most important thing about surgery for cancer is oncological clearance. So, the idea is that we need to completely remove the tumor with margins. In the head and neck, generally around 5 millimeters is a margin that's adequate, which means that even if you have a 1 centimeter tumor in the tongue, if you take this is a microscopic 5 millimeters, which roughly results to a gross of 1 centimeter, because when you put tissue in formalin, it shrinks by about 30-40%. So if you have a 1 centimeter tumor on the tongue, if you add 1 centimeter on either side, so you have anterior, posterior, superior, inferior, and then you have a depth. So then the net result of that is that you have probably a defect that is 3 by 3 by 3 centimeters, which is not a small defect. So if you draw that out, you'll realize that even for a small cancer, you end up removing a lot of tissues. So the principle is that we do an en-bloc resection, which means we remove the tumor completely and we remove the surrounding tissue in one piece so we don't spill the tumor, which means very often that we cut uninvolved structure. So we will have to cut nerves, we will have to cut blood vessels, we'll have to cut muscles, bone, if they're in the way of the tumor. And the net result of that, obviously, is that patients have that morbidity of losing that function. We do have a functional balance, though. Surgery is radical when it needs to be, but we don't do unnecessarily radical surgery, which means that we know now that 5 millimeters is enough of a margin. We don't take 1 and 2 centimeters. So we don't unnecessarily sacrifice structures that are important. I think a good example for this is tongue tumors and oropharyngeal tumors. So in a cheek tumor or a jaw tumor, even if you take an additional bit of tissue, if you take a little extra bone or you take a little extra cheek, the functional loss is a lot less. But if you take more of the tongue, especially the musculature, you take more of the oropharynx, especially the soft palate, swallowing will always be disordered. So we have that functional balance where we remove as much as we need to cure the patient essentially, but we do retain function as much as possible. So structural and tissue loss, like I said, is very important. So the maxilla and the mandible are basically important for load bearing. So there's a big masticatory load that these bones have to be able to tolerate. And when we remove that, that goes away. So obviously, if you remove the bone, chewing is disordered, and that can affect the oral phase of deglutition. There are soft tissue voids. So when you excise mucosal surfaces, deep muscular structures like the mylohyoid muscle and the tongue musculature, especially when you do these resections en bloc, you end up removing a lot of soft tissue. So it's very important for us to reconstruct that and to fill that dead space. So the idea is we replace the volume loss there. So even if our flap, which is a regional flap or a free flap, however we choose to reconstruct that, the idea is we reduce that volume loss. So we replace that volume. So even if that flap is adynamic and it's insensate, it's not functioning on its own, it at least recreates that volume. And that's very, very important for swallowing. The other thing is also vascular and lymphatic disruption. So very often, when we have arteries and nerves that are running close to the tumor, we have no choice but to cut them. So those obviously have important impacts. In the head and neck, probably the vasculature is very rich. So there's not much of an impact, for example, to ligating a lingual artery or even the external carotid artery because you have rich supply from the contralateral side. But lymphatic clearance is another issue. So when we remove lymph nodes and we irradiate the patient, we have lymphedema, which is a significant concern. So what we think of lymphedema very often is external lymphedema, where the patient has swelling on the face or on the neck. But there's also something called internal lymphedema, which means that you can have edema in the larynx, you can have edema in the pharynx, and that causes dysphagia. So now we know again that early exercise for lymphedema, lymphatic massage is very important. And when we do the lymphatic massage for the external lymphedema, automatically the internal lymphedema also improves and your swallowing dysfunction also gets better. Cranial nerve deficits and neurological sequelae are also very important. So the idea here behind this talk is for us to understand what all can impact swallowing in a patient who has had a head and neck cancer and has been treated for it. So you have the anatomical disruption, you have the removal of the tissue itself, and then you have cranial nerve deficit. So very often, if the tumor is has the nerve running through it, we have to cut it, obviously because the tumor spilling results in a recurrence. So we may have to transect the tumor, which happens for the marginal mandibular nerve, which can affect the depressor anguli oris. So the patient has a little weakness in the lip, which can cause problems with swallowing. What happens is your lip competence is reduced, so you don't have a good oral seal. So when you drink water, for example, there can be a leak from the angle of the lip. If there's a sacrifice of the hypoglossal nerve, you will have weakness of that side of the tongue so that swallowing will be disordered, speech will be slightly disordered. Again, if the contralateral hypoglossal nerve is functioning, it's pretty adequate over time. The patient learns how to compensate for that, but initially there will be dysfunction. And then lingual nerve damage also results in loss of sensation in that side of the tongue. So these also basically, these deficits cause dysfunction in the oral phase of deglutition. So the patient doesn't have any sensation on that side of the tongue. And the tongue is very important to basically move the food bolus around. So our tongue basically has to be able to feel the food there, keep sweeping it out of the floor of the mouth towards the oropharynx in order to get the bolus into the back of the throat. So all of these things, although minor, can be very significant and can be really disturbing for the patient. So it's our job as clinicians to really understand what's going on and to deconstruct this, to understand what is the anatomical disruption, are there any cranial nerve palsies, and what are the other problems that we can have. So obviously it's important that if we sacrifice these nerves, sometimes we can repair them, but even when we repair them, we do a nerve repair. Sometimes it takes a while for the function to come back. So it can be a minimum of 3 to 6 months. But early rehabilitation is really important. So here, all of you know very well. So the glossopharyngeal nerve and the vagus nerve are important because they cause vocal cord paralysis. There's a loss of the gag and cough reflexes. There can be palatal dysfunction. So when that's severe, you can have severe dysphagia, you can have silent aspiration and aspiration pneumonia. So patients with head and neck cancer who are undergoing treatment, many of them have silent aspiration. And when we don't pick that up and the patient doesn't have a good physiological reserve, they don't have good pulmonary function, they can end up with a pneumonia, which especially in the elderly age group can have a high mortality. The mortality can be as high as 30%. So you will lose patients if you don't know what you're dealing with and you don't intervene early. What about edema and airway management? So after these treatments, after these surgeries, there's always edema. So the head and neck, basically all of these areas heal well because the blood supply is good. The only caveat is post radiotherapy, healing is delayed or slow. So there is quite a bit of edema, and that onset is within 12 to 24 hours usually. It peaks at around 2 to 3 days. So that edema is quite dramatic. If you're operating in the face, you see it, but if you're operating in the back of the throat or in the base tongue, you may not see it. So it's important that you account for that. The reason for that is the disrupted lymphatic channels. You can have venous stasis and just extensive tissue dissection. So even if you get a small bump on your forehead, you get basically a cricket ball worth of swelling that takes a week to settle down. So you can imagine that if we cut into the jawbone with a saw and things like that, how long it's really going to take for the edema to settle down. So if there's flap ischemia, you can also have reperfusion injury. So all of these are possible. And it's really important for us to understand airway management. So if there's a lot of edema in the upper aerodigestive tract, it's important that we do an elective tracheostomy. So we do a tracheostomy there, basically to bypass all of the edema so the patient has basically comfortable breathing. We can usually decannulate these patients fairly early. So there's a very big difference between a tracheostomy that is done for edema and a tracheostomy that is done for airway protection. We really have to understand these two things. So in the first case, when there's edema, the idea that is that you might have some swelling in the tongue, or the tongue might fall back into the throat, and you are just bypassing that swelling. Once the swelling comes down, then you can safely remove the tracheostomy. When you have the need for airway protection, either the patient has aspiration because they're unable to manage the secretions, and there's a chance that the secretions go into the larynx and the trachea, or they are unable to expectorate. So all of us have obviously this rhythmic, continuous, reflexive swallowing of saliva. We produce around 1.5 liters of saliva every day, and we are constantly swallowing it. But after big head and neck surgeries, very often the patients lose that, especially if we don't get to rehabilitation early. So that saliva pools up in the back of the throat, it pools in the pyriform sinuses, and then it flows over into the larynx, across the vocal cords into the lungs. So if you have only edema, but the anti-aspiration mechanisms that we have are intact, which means the base tongue is fine, the soft palate is fine, the supraglottis is normal. So the innervation, both sensory and motor, are normal, which means the vocal cords are moving and they close, and you have normal sensation in the supraglottis if saliva touches those areas, then your patient will not aspirate. If it's only edema, you put in a tracheostomy. Generally, once the edema comes down in 3, 4 days, 5 days, you can pull it out. But if you have a patient with disordered swallowing who is going to aspirate, then you cannot decannulate them so easily. You need to do a swallowing assessment. You have to make sure that they're not aspirating, that rule out aspiration, not only through a bedside maneuver, sometimes with basically a formal evaluation, so a videofluoroscopy, and only then can you safely remove the tracheostomy. So what are the therapeutic interventions? So it's important that you have head end elevation. That's really important. Basically, that again prevents fluid and saliva and things trickling into the back of the throat. Strict fluid balance is very important. You don't want to overload these patients with fluid. You can give them a short course of IV steroids, tight blood pressure control. We generally use drains, so we use closed drains, we use low negative pressure drains, because otherwise you have seromas and hematomas, which can make swelling much worse. So what about radiation-induced dysphagia? So surgery, like I said, causes dysphagia in those ways. What about radiation? So radiation basically is an ionizing form of energy that kills cancer cells preferentially. And the reason why the cancer cells are killed preferentially is because the DNA in the cancer cells is damaged. It's defective, and it is less likely to be repaired compared to the normal tissues. But the trade-off with radiotherapy is that the field of radiation in head and neck is quite large. So just like we give a 5 millimeter or a 1 centimeter margin for these tumors, with surgery, you have to do the same thing with radiation, and ionizing radiation passes through the tumor and out the other side. So in acute radiation toxicity, There will be mucosal inflammation, there'll be mucositis, there can be pharyngeal edema, there can be intense odynophagia. So many of these patients need painkillers in order to swallow. Many of them need temporary Ryle's tubes in order to swallow, just to bypass that inflamed area. It generally starts, so head and neck radiation is typically 6 to 7 weeks. That's how long we have to give these patients radiotherapy. It generally starts around the third week. So the first 2 weeks are fairly mild. The reactions start at around the third week. They peak at completion at about 6 weeks. Patients after completion of radiation improve because then the normal tissue is allowed to recover. So once the radiation is stopped, the normal tissue basically repopulates and regenerates, and you start having healing. So about 2 weeks after completion of radiation, the patients feel maybe 50% better. About a month down the track, they feel about 80% better. So they need that supportive care and pain control so that they're able to maintain nutrition and hydration. Because if they're dehydrated and they're in a caloric deficit, their reactions are even worse. Many of them end up hospitalized, needing IV fluids and intense therapy. So the rule of thumb is a little bit of weight loss is acceptable, but your patient should be able to take enough nutrition and hydration that they have normal energy levels. So what happens typically is patients eat and drink less, and then they go into like a reserve mode where they don't expend much energy. That's how they save energy and reduce their energy requirement. The patient should be getting enough food and drink that they can remain fairly active. If that's not happening, or you think there's aspiration, put in a Ryle's tube, keep it there for a few weeks, and you can always remove it later on. Now, what happens over time is that there is radiation fibrosis. So initially, there's inflammation of the tissue. Then what happens is because of microvascular internal damage and obliteration, there's collagen deposition, and then the normal elasticity of these structures is lost, and you have strictures. The biggest problem for us is what we call the DARS, so the dysphagia and aspiration related structures, which are in the neck. So the constrictors, for example, are very important for the pharyngeal and the esophageal phases of this of deglutition. So what happens is initially, as long as the patient is swallowing, these muscles are moving. That's good. But then later, what happens is this long-term inflammation results in fibrosis, and once fibrosis happens, then there is basically permanent stricture formation and there's dysphagia. So it's really important that patients swallow during radiotherapy. There's a lot of data that shows this. We need the patients to swallow, which is why we now do very few pegs. The reason why you don't get so many pegs pre-treatment from your head and neck colleagues is because there's data that when you put in a peg, the patient automatically doesn't swallow. And the net result of that is that they have long-term swallowing dysfunction. And if the constrictors undergo fibrosis, the patient will never swallow normally again. They'll end up with a stricture and long-term dysphagia. So we have to get them to swallow. A Ryle's tube that way is a little better. A peg basically reduces the motivation for swallowing. Not that pegs aren't valuable, but I'll talk about where we do have to put pegs in. But generally, we put in Ryle's tubes because we want them to use that for a shorter period of time and we want them to continue swallowing. So, what are the assessment tools that we have? So, there are mainly two tools that we use. One is FEES, or flexible endoscopic evaluation of swallowing. So, this is basically where we put in a nasopharyngeal laryngoscope. It's a small camera that goes into the nose and it sits above the larynx where we can see what happens when you swallow. You try different consistencies of material, and you also use different colors so you can see staining. Typically we use food dyes like green dyes, so you can see if there's aspiration, you can see if liquid has made its way beyond the vocal cords. The idea is that you see basically in live, basically it's a live action reflection of what's happening when the patient swallows. So when the patient swallows, how easily is it going? Where is it going? Is there aspiration? The limitation is that there's a whiteout phase during swallow. So what that means is once the patient swallows, And during that oropharyngeal phase, there's an immediate whiteout, and you can't see anything for a second or two. And you cannot see the oral phase. So the whole thing is that the endoscope sits in the nasopharynx above the oropharynx so that you can see a bird's eye view of everything, but the food has already basically passed through the mouth. So abnormalities in the oral phase you can only see with a videofluoroscopy. A videofluoroscopy is basically you can either do a modified barium swallow. What we also use is a gastrographin, and we've published on that. We use a small volume gastrographin, which is just as effective. So this gives us a full dynamic view of the oral, pharyngeal, and the upper esophageal sphincter mechanics. It helps us see the transit. The limitations are you do need radiation exposure, unlike fees, but it is a very small dose of radiation, and you do need a setup. So you need a radiology setup, and you need a lot more sophisticated equipment, unlike a fees. So I'm just going to run you through a video of what a feast looks like, just for you to get an idea. So these videos came to me from a colleague, Dr. Vidyadharan. So thank you for that. So this is a Riles tube. So we are seeing an inverted view, no different than your esophagoscope. So this is the epiglottis, and we are seeing the right aryepiglottic fold, and you're seeing the Riles tube, which is going through the pyriform fossa. So if you look at this immediately, what you notice is you can see that the right vocal cord is not moving. You can see the A fold moving well. You can see all these secretions. So whenever you see all those bubbles and secretions, it means that the patient's swallowing is disordered. There's pooling of saliva and other materials there. So you can see here that there is a palsy of the vocal cord, and you can see this thin ballooning of the epithelium, which we usually see when there's edema in the AE fold. You can see the Riles tube going through there. You can see this residue in the vallecula. So you can see that the patient has tried to swallow something. You can see a vicryl stitch there because the patient has had surgery in the base tongue. And you can see that vallecular residue, and you're seeing that the residue is not going anywhere. So the whole idea here is we're looking at when you give the patient solids, what's happening. Uh, is the patient able to swallow their own saliva? So here we are seeing that the vocal cord is not moving on the right side. There's edema in the AE fold, vallecular residue, and overall disordered swallowing. So you're seeing a lot of residue. We're seeing that nothing is really going anywhere. And you can see that the left side is normal. So you can see that the left vocal cord is normal, and you can see that the pyriform sinus is normal. So very simple fix here. So if you see anything like this, all you have to do is you have to ask the patient to turn to the opposite side. So the problem here is the patient may be right-handed. They're probably putting food into the right side of the mouth. It's not making its way down to the vallecula, and there's a lot of stasis. So if the patient simply turns to the left side and uses that pyriform fossa, eats on the left side and tucks the chin, you will be pushing food into the normal pyriform fossa. So if you do that, the patient will swallow a lot easier. So very often it's really not that complex. It's just identifying what the problem is and trying to fix it. So in this patient, we know that the right PFS is not opening up. We know that the A fold is not moving adequately. There's a lot of edema. So if you just ask the patient to keep the ear on the shoulder and tilt the chin and load food onto the left side, you'll be forcing food down the left PFS, which is normal. So immediately the patient will start to swallow a little better. So this is why it's important to do a study like this. It's important for us to understand. Otherwise, we will think the patient is, swallowing very well. And also what we see in patients who are elderly very often is you can have other swallowing abnormalities. So what we see regularly is you might have Parkinson's and other problems. So in those cases, you have neurological abnormalities with swallowing. So you have the surgical or the radiation related dysphagia that is superimposed on that. So then what happens is if you treat those neurological causes, you identify Parkinson's from swallowing disorders, which we do sometimes. So patients come to us with dysphagia and we turn out to diagnose Parkinson's. You treat them with the medication, and then immediately the swallowing improves. So this evaluation is really, really very important. Rather than just leaving the patient, with a Riles tube for weeks and weeks, or just going ahead and doing a peg because they're not able to eat, it's really important for us to understand what's going on. The next is a video fluoroscopy, and I'm just going to show you one video here. So you can see that the patient has had a jaw reconstruction, and there's a plate here. So that's a plate that we use to reconstruct the jaw. You see the dye in the mouth, and you can see that the patient is swallowing. So you can see it moving down. You can see a few things. So number one, you look at the oral phase. So now you can see the patient swallowing. You can see the mandible is moving. You can see hyolaryngeal elevation. So that's very important. You can see the larynx moving up, and you can slowly see the dye moving down. So in these cases, you can see that it's disordered. You can see how slowly it's moving. You can imagine when you swallow a glass of water, how fast that transit should be. It's really very slow. So we can see here that once it hits the oropharynx, there's no problem with the esophageal phase. So this is purely oral dysphagia. So we would have never picked this up on a fees, right? Because we cannot see the oral phase. The problem here is purely oral. So the patient's unable to get this bolus into the back of the throat and down into the oropharynx and esophagus. The minute it hits the oropharynx and esophagus, it's literally like a water slide. So we have to look and see what's happening. So again, we look at the mouth, we look at whether the flap is bulky, whether the patient has a hypoglossal nerve palsy. We see whether they have to eat on the opposite side of the mouth. So both of these are complementary. When you have a patient who's not swallowing well, they're complementary and you can really put them together to get a lot of information. So you have to also do a lateral view, very important. You can't do only a AP view. A lateral view is equally important for multiple reasons. And the most important reason is to look for aspiration. You won't see an aspiration in an anterior-posterior view. You'll see it only in the lateral view. So you can see the air in the trachea here. So you can see exactly what's happening. So basically, you can see that once it crosses the oropharynx, the transit is quite fast, but all of the struggle seems to be happening in the back of the oral cavity, right? So I'll show you that again. So this is the dye that's going into the mouth. It's pooling up into the back of the mouth. The patient is swallowing slowly. It's taking 2 or 3 swallows in order to get this from the oropharynx into the esophagus. So this is oropharyngeal dysphagia. So we need to look in the back of the mouth. We need to look at the flap. We need to look at the cranial nerves and see what's happening. So when you put these evaluations together, they really give you a lot of information because every patient is different. It's not the 2 patients of oropharyngeal cancer who have gotten radiotherapy have the same exact pathology. Absolutely not. It's very, very personalized, which is really important that we all understand and put our heads together. So when we look at temporary versus permanent dysphagia, the rough cutoff we have is less than 6 months. So 2 to 6 months, and we have permanent or chronic dysphagia, which is more than 6 months. So less than 6 months, we typically have post-surgical edema, you have inflammation, you can have neuropraxia and acute pain. With chronic dysphagia, you have muscle loss. You can have that because of cranial nerve palsies. The nerves then get fibrosed. You can have nerve transection and you can have late radiation fibrosis. The onset and trajectory that so for temporary, it's immediately post-op or radiation. Its onset, it's steady and progressive. However, it's usually self-limiting. So for surgery, the dysphagia is always the worst initially after surgery, and it gets better. For radiation, it steadily gets worse. So it starts showing up in the 2nd or 3rd week. It peaks at the 6th or 7th week, and then it gets better. So the pattern in which it presents and progresses gives us a lot of idea as to what's going on. So permanent is usually insidious post-RT or plateaus or worsens over time. So with a VFS or a FEAS, temporary dysphagia will be mild to moderate, and they generally respond to compensatory swallow maneuver. So just like I told you, you tilt basically so your shoulder touches your ear. On the opposite side, you tuck your chin. All of these things work very dramatically. Believe me, patients can have their Ryle's tube out literally in a week, even though they haven't been swallowing for a long time. With chronic dysphagia, you can have severe persistent pharyngeal residue. You can have silent aspiration and anatomical rigidity. So it's very, very important that you understand who are the patients who are aspirating because otherwise these patients can die. You can absolutely lose them to aspiration. So if you think the patient is aspirating and you see that on a video fluoroscopy, you want them basically on a peg. If you think that the aspiration is going to be prolonged, don't put in a Ryle's tube, because a Ryle's tube can worsen aspiration, because the Ryle's tube goes across the upper esophageal sphincter and allows reflux. So if the aspiration is mild to moderate, and you think it's going to last for at least 3, 4 weeks, put in a peg straight away, especially if the patient has reduced pulmonary reserves. If it's an elderly patient, you don't think that they'll tolerate a little bit of aspiration. If it's severe and the patient will not tolerate even saliva, they're not able to manage their secretions, then you do a tracheostomy straight away, no confusion. So if it's only food related, it's only food and water that they're aspirating, but they're able to manage their secretions, then you get them off any oral feeding and put in a peg. But if you think that they cannot manage even their saliva, straight away tracheostomy. So temporary dysphagia has a high recovery rate. There's reversible tissue swelling, and chronic or permanent dysphagia usually is irreversible, and the outcomes are quite disappointing. So, what are the indications for PEG placement? So, like I told you, frank aspiration risk, severe pharyngeal dysphagia. So, now the cutoff for us is 28 days. So, if you think a patient is going to need a Ryle's tube for more than 28 days, go ahead and do a PEG. There are multiple advantages of a PEG or a Ryle's tube, which I certainly don't need to tell my medical gastroenterology colleagues. But when do you defer a PEG? So when you have mild dysphagia, you think the patient is going to get better, there's a short recovery window, and if there's a patient preference. So if you think the patient's going to get onto oral trials quickly, that's good. So PEG timing is very important. Very often you hear patients saying that, let me get to radiotherapy. Let's see if I'm able to swallow, then I'll do the PEG. Absolutely not. Do the PEG before the radiotherapy. Continue swallowing along the PEG, because we don't want a treatment break. We don't want the patient to have, malnutrition, dehydration, end up with complications. So if you feel a patient's definitely going to need a PEG, do it before the treatment. Acute post-op, we for our patients who we think are going to need PEGs, we do them intraoperatively. So we do it when the patient's anyways under general anesthesia. Reduced mouth opening and other things are not a problem. So what are the GI management risks for patients with severe reflux and GERD? We have to manage those. Sometimes you can have a buried bumper. So there are multiple ways to prevent that, and tube clogging or dislodgement. So our favorite is to put in Coke or Pepsi or 7-Up. Patients are always a little shocked when you suggest that, but it really works. So for patients post laryngectomy and after radiation, they have a high chance of strictures. We generally want to get in dilatations early. So we don't want to start doing basically dilatations after 1 year or 2 years where they won't work at all. So we want early intervention. We want, a structured plan for dilatation so it gets a lot better. It's important to intervene early. Early swallowing rehabilitation protocols are very, very, very important. There's no way around them. Uh, Sometimes we are a little busy. Our swallowing therapist may not spend time with every patient, but it's important to realize who are the patients who really need it. And all of us have to know swallowing intervention. So, what I showed you is basically what I would be telling the patient. I would be advising them how to swallow. If they're having a tough time, we'll get our swallowing therapist to spend some more time. So, there's no way that we can treat these patients without having a fundamental knowledge of all of these things. So the multidisciplinary care timeline is you have an initial bedside assessment or fees assessment early. When you get to 1 to 4 weeks, you may need a biweekly fees or a VFS, and then you start swallowing exercises. By month 3, you need to take call on what's happening. Do you think it's temporary or permanent? Do you need to intervene? And beyond 6 months, it's really important for us during regular cancer checkups to look for dysphagia, identify patients who might have strictures, and send them across to you for an endoscopy so you can dilate. This again, I don't need to run through. I think you know very well. So these are the VFS and fee scores for aspiration, where we grade the risk of aspiration. Very important for people to know. And also the CTCAE. So for the radiation-related side effects, how we grade the severity. So this is basically what I had. The idea was to give you an idea of what troubles our patients and how to look at this basically through different, I think, silos that function independently. So, what are the functional disturbances that we cause as surgeons? What are the temporary and permanent problems that the patients can have superimposed on top of this? What happens with radiotherapy? And how do we kind of work together to solve all these problems? So, I hope this has been helpful. Happy to take any questions or comments.
Thank you for the lucid talk, Dr. Narayana. It's a very simplified session on a complex topic. A lot of nuances had been covered in this talk, especially on the role of rehabilitation, which plays a very major role in this subset of patients. And we know that the if not done properly, it could be mortality, which is the main problem. So, uh, the importance of peg placement is a very important thing. Timing it preemptively and acting upon is very important. So, of late, we have been discussing on topics related to the oral and the upper esophageal phase of swallow, and definitely the sessions will never end without addressing a session on post head and neck surgery related dysphagias, and also the ones related to radiotherapy and other things related to this. So, we are very gifted to have great speakers like you talk on a complex topic. For us, esophageal phase is a very simple one, but then a coordinated one. But when it comes to oral phase and the pharyngeal phase, it all happens in milliseconds with a lot of complex things happening, which a probable human mind will need to take a lot of time to decipher them. And you guys have all made it easy for us to understand them quite well.
For
So,
us, it's the other way. Huh? For us, the oral bit is difficult. The esophagus is for us very difficult to understand. So I think it's all about what we do every day and what we understand.
it's a mutual thing. So, what I can understand of late is uh, surgeons actually coming to us and are able to actually think of peg placement even before they feel that things could go wrong. So, if nutrition has been basically has been very transforming. They know that nutrition is going to get bad and the outcomes are going to be bad. Peg placement has been considered quite early in the management of the patient, and the timing between the protection of cords, then comes the basic secretions, then the danger of aspiration, and timing is a very important thing, which again is an evolving topic, and we could have more refined answers over time. Though there is some gray zone on when exactly it has to be done, but then if the understanding is there from a patient's perspective, things are all timed at least to the best possible manner. It's a complex topic. That's why a team decision, a multidisciplinary team decision plays a really important role in management of the patient in an overall way. With recent exposure of more PMR patients who are post-surgical and post-neuro dysphasias, the understanding has been the importance of the swallow therapy has really been a game changer. The rehabilitation part is something as physicians we would probably not think that it would make a difference. We straight away go for Riles tube followed by peg tube, and if no improvement, a lot of things. But then the rehab, what difference it could make. Actually, sometimes with an appropriate posture, it can be instantaneous improvement. And initially, we will think this thing intervention is required, but then just that small postural change could, in fact, tilt the balance towards the patient from a nutritional perspective, and in turn, morbidity and mortality too. So, great. Dr. Narayana, any takeaways for us on the timing? Because you have told that the surgical aspect, the 5 1 resection, the edema, and when it's temporary, you guys, the patient needs support for a very small time. Where do you feel that the patient may require much longer peg tube placement? Because I've seen both ways happening. Some set of patients where peg tube has been placed early and they recover quite soon and they have to be removed quickly. Sometimes they have been referred quite late in the picture, and so the timing of peg too early is also a problem, too late is also a problem. So where do you feel it fits the balance quite well?
I think that's a good question. And I think experience and multidisciplinary discussion is important. So, the patients who are undergoing surgery first, if their disease is not very extensive, you're not going to resect the base tongue, you're not going to resect the tonsil and the soft palate. The dysfunction in swallowing is not too bad. So, I wouldn't put in a peg for them. We are very, very aggressive with swallowing. Most of our patients who have had major head and neck cancer surgery are swallowing without a Ryle's tube by day 10. That's unusual. Many surgeons aren't that aggressive. But the reason why we do that is very simple because when they need to go for radiotherapy, we need the constrictors moving well before radiotherapy starts. There's a lot of data that says you keep the Ryle's tube and you send them for radiotherapy, they end up with strictures and they never swallow again. So where we do a peg upfront is if you have a significant part of the tongue base going. So if you're going to lose a lot of the tongue base, there will be no oral oropharyngeal phase of deglutition. Be very clear on that. Whatever you do, you put in a flap, it's adynamic, it's insensate. So the patient can feel the food, the patient can move the food. If there's significant soft palate involvement, again, so that pharyngeal squeeze requires the soft palate to be intact. So that whole pharyngeal squeeze that happens in the oropharynx depends on the base tongue, soft palate, tonsil. So if you're cutting all of those muscles, don't expect the patient to swallow. Put in a peg, rehabilitate them peacefully. Again, if you have had a patient with prior radiotherapy, we do a lot of salvage surgery. We do maybe 30 to 40% of our patients have undergone radiation previously. Again, if it is a lateralized defect, so if it's a buccal, it's a jawbone, it's a lateral tongue, they recover quite easily. If it's base tongue, if it's palate, they recover slowly. So if there's a significant palatal resection, put in a peg. If the patient is going for radiotherapy and it's an oropharyngeal cancer, so an oropharyngeal cancer, typically we treat with radiation first, we don't operate them upfront. If there's significant soft palate involvement, follicular involvement, put in a peg. Right? The reason is again the patient will not swallow, they will aspirate, their nutrition will go down, they'll have treatment breaks. The thing about a peg is my threshold for a peg is quite low. If I think the patient is going to benefit from it, I don't think it's an invasive or a bad procedure. I tell the patient to swallow along with a peg. So if I think the patient is going to need a Ryle's tube for more than 4 weeks, absolutely no discussion. Patient gets a peg. For patients who I think can have the Ryle's tube out in a reasonable amount of time, couple of weeks, then I wouldn't put in a peg. Again, patient who you're expecting a lot of surgical complications because it's they've had previous radiation, very extensive surgery, put in a peg. So I think there's a delicate balance there.
Cool. So we have a question by Dr. Mohammed. Sir, you mentioned that early post-operative dilatation can be done if there is esophageal narrowing. Is it advisable to perform dilatation when the mucosa is edema, it is in edematous state?
Good question. Definitely not. So when we say early post radiotherapy, we mean 3 months, not earlier
3 months.
than that. Yeah. So we are talking about 3 months essentially. And again, you are dilating not for the temporary, you are dilating to prevent the chronic. So you're preventing the fibrosis. So basically, you do it at 3 months, not before that.
So what you basically meant was there's a high probability of stricture. So we
Correct.
don't wait for a significant stricture. The dilatation by itself becomes too risky. So as it is late in the process, but not too late that the patient gets into severe stricture and becomes dilatation process itself becomes a complication in a way. Great.
Correct.
So awesome, Dr. Narayana. It's been wonderful, and of late, the such sessions are basically being held to generate the thought process and thinking in niche topics so that patient care improves much better. Of late, what we really realized is swallow is very important, and rehabilitation plays a very important role. And time and again, interpretation of these tests like let it be modified barium or the fees, it all has to happen in a coordinated way. And your session definitely has taken a small but a significant step towards better patient care from a gastroenterologist perspective also. Thank you for accepting our invitation and making us understand this topic in a much more clearer fashion. Thank you.
Most welcome. Thanks a lot.